This is the Dental Up Podcast, your daily source for insights from dentists and leaders in the industry. Brought to you by Keating Dental Lab, a full-service, award-winning dental lab that is here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.
Well, once you have the problem, then you have to look at, when I see that patient in my office, you have to look at several factors. You have to look at what is the pattern of bone loss around this implant. Is it horizontal bone loss, flat type bone loss, or is it a vertical defect similar to what we've seen in periodontitis? And we've actually looked at that with a long-term, consecutive, randomly controlled clinical case report that we published back in 2019. We looked at treating peri-implantitis patients, and we only looked at 20 consecutive patients that exhibited 23 implants. And around those implants, we identified 84 defects that were 6 millimeters or greater in depth. In fact, the mean pre-treatment probing depth in those patients was 8 millimeters defect around those implants.
Goodness.
And the reason we looked at 84 defects around 23 implants is one of the things that you see in the literature is some reports will cherry pick a defect. So they will say, okay, I treated implant number 12 that replaced tooth number 12, and it had a 7 millimeter probing depth around it or pocket around it, and I treated it and it turned out great. We all know that there likely are multiple defects around an implant that has peri-implantitis. And quite frankly, we've seen that to be true in our study. When we looked at these 20 consecutive patients having 23 implants, we actually found 84 defects around these implants when you probe them circumferentially that were 6 millimeters or deeper, and their main pre-treatment probing depth was 8 millimeters. Well, many of these patients had vertical defects, and we treated those vertical defects with a surgical approach. And I've come to the point in my career that once a patient has been diagnosed with peri-implantitis, it is clearly a surgical treatment at that point. It is a surgical approach. We enter those defects with minimally invasive procedures and a minimally invasive flap reflection so that we have access to the contaminated implant surface. We have access to the inflamed granulation tissue within the defect, and we're able to affect our regenerative procedures and materials in order to attempt to regenerate bone around these implants. Regeneration of bone around implants in vertical defects is key to probing depth reduction, and probing depth reduction is key to plaque control and maintenance. So when we looked at these patients 12 months after regenerative treatment, we were able to achieve a 4.4 millimeter probing depth reduction at 12 months.
Wow.
And we were able to look at pre-op 8 millimeters of defect. And now our mean probing depth 12 months later was approximately 3.6 millimeters in mean probing depth. That study was actually published in 2021, I believe, and those actually published in 2019, and it can be accessed through search on the International Journal of Peri-Restorative Dentistry, 2019, treatment of peri-implantitis with a combination of the erbium YAG, laser decontamination, and regeneration. When we have horizontal defects around implants, that's a whole different approach. Those are not amenable to bone regeneration. You're really probably looking at some type of resection and probing depth reduction therapy, similar to what we would do with periodontitis. That, of course, becomes an issue in the aesthetic region, and that becomes a difficult issue to resolve. But if we have these advanced lesions and vertical lesions, I believe we're able to affect many positive changes in those regions.
Excellent. We'll post a link in the text in the write-up to your studies. before we publish this, and
That'd
we'll
be
get
great.
that out there. Yeah. Okay, so you mentioned that horizontal bone loss is obviously the more severe situation. Do you have any data on the vertical bone loss that progresses into horizontal, or to the percentage of cases with horizontal defects that eventually lead to worst case scenario is loss of the implant?
We look in terms of treatment applicability. Essentially, horizontal bone loss can progress into vertical bone loss. If vertical bone loss then goes to horizontal, what that means is you're losing a lot of crestal bone.
Right.
Typically, the general feeling in the literature and in talking to those that are involved in peri-implantitis treatment, once an implant has 50% bone loss or greater, then you really need to consider removing the implant and starting over. That becomes a clinical decision. That decision is based not only on the individual implant, it's based on the patient, their age, how old the existing implant is, what their restoration consists of. So this becomes a difficult challenge when you have multiple implants that are splinted together in large full arch restorations. You have to look at, can this implant be removed and the prosthesis simply replaced? That's one of the advantages of doing screw retained restorations, particularly with multiple implants and large reconstructions. I always advocate for screwed in restorations for several reasons. First of all, with a screw retained restoration, you avoid the conundrum of cement. With a screw retain restoration, you have retrievability so that this can be removed and adjustments can be made. And if there are multiple implants that are splinted, it may be a question of removing the offending implant and retaining the rest and the current restoration. It could be that you have other restorative options that you can take advantage of. But when you have a cemented restoration on multiple implants, and you have an issue around one or two of the implants, it becomes a much more difficult problem to solve. And we generally try to manage those by keeping the restoration in place and working around the implant with the restoration in place.
All very good points, and your explanation is extremely logical, which I appreciate. That brings up a couple other questions that we get here personally as lab technicians all the time. What is your feeling on connect implants to natural teeth and your preference for loading, either immediate or delayed after full integration?
There are actually some data in the literature talking about implants connected to natural teeth. And this has been quite controversial because we see that there have been reported changes around the restoration and the natural teeth, as the natural tooth can walk away from the implant restoration
Right.
simply because the implant is rigid. The tooth has a periodontal ligament around it, and it can move. And with the restoration or splinted framework having some flex, the implant essentially carries all the load. And so you essentially set up a diving board. However, there have been some literature that indicates that, oddly enough, cemented restorations on those implants and cemented teeth fare better. I would tell you that from my perspective, if I can have individual non-splinted implants, to me, that is the ultimate restoration in terms of easeability of restoration and in terms of maintenance, should we have issues down the line. However, I have softened that approach as my patients age. My patients, when I started practice, were 40, 50, and 60. And then they all of a sudden became 50, 60, and 70. And now they're 70, 80, and 90. And so what do I do with an 85-year-old that has a partially edentulous segment and a paucity of bone? And can I involve some natural teeth in the restoration? Or can I advise restoration of this patient with a minimal number of implants? As a general rule, though, we try to avoid connecting to natural teeth. I'm not saying it's never been done. And that is a very individual decision and not a routine one.
That's great guidance. And again, it goes back to treating the patient as individual and not fitting them into only one category. Our feeling here at the laboratory is we like to incorporate a type of stress breaker in the restoration. If we're going to if we're going to connect, we'll either use a telescopic coping or an extracoronal attachment for that.
Yeah, because the issue for you, for the dentist and and for the laboratory is if that tooth starts to quote unquote walk out of the restoration, you're going to get decay around the tooth.
Absolutely.
The other view perspective, though, however, is that if the tooth is walking out of the restoration, then on the other side of that, the implant and the implant abutment is taking the load because the tooth is literally moving away from the load. So I've seen when that happens, that not only we have a risk of decay around the tooth, we have a risk of screw fracture on the implant or implant fracture, chipping and breaking of porcelain, because now those loads are uncontrolled.
All great observation. We've seen each of those problems actually here. And again, it's one of those things we try to avoid these, but that's the reality is we have clinicians that want to connect and we see hardware failures, we see porcelain failure, but that's life. The mouth is a funny place and every patient really is different too. Some patients where we've connected two teeth to one implant and constructed a 5-unit prosthesis, yeah, we have data that these restorations have been intact in the mouth for up to 15 years. And we have other cases where we see come back in under a year for fracture or hardware problems. And that's
Right. And this also brings up another point about implants in general. And I'm going to digress a little bit from peri-implantitis just to talk a little bit about treatment planning, particularly in posterior segments. We used to think that longer implants were better and bigger implants were better. And over the years, and the literature is pretty clear on this now, that that's not actually the case. And one of the frustrations that I have as a clinician who treats peri-implantitis, if I have a patient that comes to see me that a referral is sent to me and they have an older implant in that was done someplace else, and they have a 15, 18, 20 millimeter implant in, there's really no need for that anymore. And should that implant need to be removed, that becomes a significant issue in terms of the invasiveness of the surgery to remove that implant. Our implants typically are anywhere from 8 to 10 millimeters in length. Some of them may be 12 millimeters in length. And we have implants that have done extremely well, 6 millimeters in length, provided that they're splinted. And the data is pretty clear. The issue of supracrestal ridge augmentation versus shorter implants, the shorter implants do just as well. And so we have gotten away from these extremely large and long implants. I've seen implants that come into my office that are molar replacements that are 6 millimeters in diameter. And what happens is they use up all the bone, facial and lingually. And as a result, they get bone loss and peri-implantitis either on the lingual aspect of that implant or the facial aspect of that implant. And so our treatment planning has changed over the years, and smaller, shorter implants are not necessarily worse. And in many cases, smaller, narrower implants are actually better. And that speaks to the material advances in dental implants themselves. These implants are stronger, they're tougher, they can withstand greater loads than implants that we did 20, 30 years ago. And as a result, they have become shorter and smaller. And if worse comes to worse, if those implants have to be removed because of peri-implantitis, it becomes a much more predictable, much less invasive procedure to do that and to restore the patient again.
Yeah, that's advances in engineering and biomedical science. And that's what allows us to improve patient care. You're talking about 12, 15 millimeter long implants. So I'm trying to envision that on the scans that I saw last week, and it was like, gosh, I don't think we could fit many 12 to 15 millimeter long fixtures in a lot of the cases that I saw.
And I will say, based on our cone beam scans and based on now using shorter implants, paresthesia, posterior mandibular paresthesia, or anesthesia because of damage to the inferior alveolar nerve has really been a non-issue for the last 10, 12 years. Unfortunately, I see it coming into the practice. There's not much I can do for those patients, but typically when I take a look at that, either two things have happened. Either it was not a complete diagnosis and treatment planning with regard to implant placement and length, or the implant is just essentially too long. And it's an unfortunate circumstance that fortunately is rare now.
Yes, fortunately, it is rare, and I agree with that. It's something that's should be entirely preventable with today's diagnostic tools. It goes back to that old adage, measure twice and cut once.
That's right.
Yeah. Dr. Clem, I really want to thank you. I know we've gone over and I know you have a busy schedule of patients. Is there anything important that you feel we left out or didn't cover before we sign off?
I would tell you the one thing that advances are still required for is dental implant maintenance and dental implant maintenance education. So I speak to a lot of hygiene groups, and we have one of the largest dental hygiene study groups in Orange County. We typically will communicate with about 150 hygienists 2 to 3 times a year. And the hygiene protocol with how to maintain implants is all over the board. Some hygienists are afraid to even touch an implant because they're afraid it's going to explode. Other hygienists consider using plastic probes or special probes. They don't know what instruments to use to maintain the implant and affect plaque control. And those instruments that are available to them are rare, quite frankly. They're not a lot to consider. There's resin type curettes, there's titanium curettes. One of the newer innovations that we're exploring now is a Perio-Flow by Hugh Freedy, which is the abrasive glycine jet that can debride implants subgingivally. The lasers have not been effective in a non-surgical use. In fact, the literature in terms of laser bacterial reduction has been absolutely non-effective. There hasn't been one long-term study that's proven its effectiveness. So I think the one aspect that actually needs to be studied now is how to maintain implants and how to achieve a predictable preventive protocol for maintenance of these fixtures long term.
It's an extremely important point that you just made. Maintenance and education on the hygienist part is paramount in this. Do you have room in your study club for more? How can our local customers find your study club?
From our study group, we generally are having those hygienists from practice that refer to our office
Sure.
included in our group. However, if they'd like to at least explore some of the aspects of the hygiene study group, I will give you a link and they can link to a staff person in our office that handles that, Monica Trementosi, and we can at least help in terms of giving them some information and sharing some of our thoughts with them. And like I tell all the hygienists in Orange County and the general dentists, if they ever want to spend a day in our office with our hygienists, they're more than welcome to. And that's the best thing that I can do for those hygienists, even if their offices don't work with us on a regular basis. The opportunity to sit with hygienists that have been doing this for 25 and 30 years, and all they've seen is periodontal patients and dental implant patients, it can be a revelation to them when they look at our protocol and learn what we do, and we're happy to share that.
Wow, that's a phenomenal gesture on your part. And it's extra work, but you've been a lifelong educator, and that's really what it's all about, is getting your knowledge into the hands of more people for better outcomes. And I thank you for that.
My pleasure. I want to thank you for the opportunity to at least share some thoughts. What I'll do after we complete the podcast is I'll give you some links and you can put those when you publish this. And any questions that you have or any of the clinicians have, I'm always available. And I'm happy to do it. And it's been a privilege and an honor for me to participate in the profession, particularly in Orange County. It's been a great run and more to go.
Well, Dr. Clem, you're an icon. I can't thank you enough for this. Even though we've never met or spoken before Friday, I've been a big fan of yours for a long time. I've known a lot of other dentists and technicians that have participated in your study club. And let me tell you, the feedback is 1000% positive. And you're a tremendous man, tremendous dentist, tremendous educator. And I thank you for everything.
I appreciate it and appreciate the opportunity and enjoy the rest of the week. And I wish everybody good health and happiness and successful practices.
Dr. Clem, thank you so much.
Appreciate it. Take care.
Thank you for listening to the Dental Up podcast, your daily source for insights from dentists and leaders in the industry. This episode is sponsored by Keating Dental Lab, here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products, and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.